Dear colleagues, in partnership with the Deutsche Gesellschaft für Nephrologie, the Österreichische Gesellschaft für Nephrologie, and the Société Francophone de Nephrologie Dialyse et Transplantation, Marcus at Home welcomes Dr. Samia Mora in Boston, Massachusetts, and Dr. John Cleland in Glasgow, Scotland, in order to discuss the use of aspirin in primary and secondary prevention of atherosclerotic cardiovascular disease. Dear Samia, dear John, we are honored to host you this afternoon in New England, this evening in Scotland. Thanks so much for joining us.
It's a pleasure.
My pleasure.
Thanks from my side as well. Just as a brief introduction for everybody, Dr. Mora is a cardiovascular medicine specialist at the Brigham and Women's Hospital and director of the Center for Lipid Metabolomics. She's authored more than several hundreds of scientific papers, and after that is also editorial board member of JAMA Internal Medicine as well as atherosclerosis. She's been in the steering committee of the Jupiter trial, the Vital trial, and is also very much involved into prevention considering platelet inhibition, so aspirin basically, and she has, together with some colleagues, recently developed the Aspirin Guide mobile app for aspirin in primary prevention. So that's also very interesting. We're keen to see what she brings along for that topic. Dr. Cleland from Glasgow, I think Professor Cleland doesn't need much of an introduction, director of the Center for Biostatistics there, a large clinical trial units and involved over years already in several large number of trials in prevention, and also heart failure is a very important part of his work. He's had some training at the Imperial College in London, returned back to Glasgow, and he's actually founder of the European Journal of Heart Failure. So, Professor Cleland, we're very happy that you joined our discussion and followed our invitation, which arose actually after he wrote an editorial about the well, maybe not so great scientific database on aspirin in secondary prevention long after a cardiac or vascular event. So we're also very keen on your talk.
Yes, so thank you very much for that introduction. My pleasure to be here today to talk about aspirin for primary prevention. And this is a topic that's controversial, and we'll discuss some of the highlights of that. As we know, aspirin is a very old medication that's been used for thousands of years. One of the earliest mentions of aspirin is in the Egyptian Ebers papyrus, shown here on the left of the screen. And at that time, it was known that there is a substance in the willow tree or bark and the leaves that can actually have anti-inflammatory properties. And it was used at that time more for its anti-inflammatory properties. Also mentioned in the Sumerian tablets from ancient Mesopotamia. Now, it took thousands of years, but then in 1899, it was manufactured. Aspirin, pure aspirin, was manufactured. And since then, it's been tested in thousands of participants in studies. However, aspirin for primary prevention is still controversial, even though we have actually more than 100,000 patients from randomized clinical trials that have examined this question. And I like this hashtag, when it comes to aspirin, I don't know anymore, or aspirin in primary prevention is complicated. I think that's a lot how we feel about aspirin in primary prevention. I will show you some of the summary data because there are many, many studies. But this is one of the meta-analyses that summarizes all the randomized clinical trials in primary prevention for low-dose aspirin. And what we see here is that together, the composite endpoint is about 10%. In this meta-analysis was 11% relative risk reduction. And that's driven by reductions in myocardial infarction, about 15%, and also in ischemic stroke, a 20% relative risk reduction. Total mortality, cardiovascular mortality in general, is not significantly reduced. In part, that's because the primary prevention populations are healthier, and the duration of the trials is usually on average 5 or at the most 10 years. So it's hard to see a significant reduction in mortality in primary prevention. Now, for risks of aspirin, the risk and the benefit have to be weighed very carefully. So the risks of aspirin are that there's about a 40 or 50% relative increase in risk of bleeding, major bleeding. there's about a 30% increase in risk of intracranial bleeding, which is, of course, more rare, but that is more the one that people and patients, of course, worry about is the intracranial bleeding. So this is a summary of the data in primary prevention, is that it reduces cardiovascular events by about 10%, and this is on top of other preventive therapies, including some contemporary cohorts. That's the totality of the data. However, the risk is that there is major bleeding that's increased by about 50%, and no reduction in all-cause mortality. As shown here on the slide, these are highlights of the primary prevention studies, and you can see there's no significant reduction in mortality. One of the studies, Aspirin, shown here at the bottom, in older patients showed an increased risk, but all the other studies really showed no risk. So the sum of the data is that there was no increased risk. There is one study I wanted to highlight, because this study predominantly led to some of the European Society of Cardiology recommendations, which is the ASCEND study. This was conducted by the Oxford group, and what they tested is, it's a very large randomized trial. It's actually a 2x2 factorial, but the part we're focusing on here is aspirin versus placebo. The other 2x2 factorial was omega-3, which had no effect on the primary endpoint. Aspirin, shown here in red, led to a reduction in cardiovascular events. As you can see, the study was up to 9 years, but on average it was about 7-year follow-up. And it resulted in about 12% relative risk reduction, as well as there was an absolute reduction of about 1% in terms of vascular events. And this study was conducted among patients with diabetes. So these are primary prevention, but they have diabetes and often have other cardiovascular risk factors. So there have some other studies, and this is one of the ways aspirin has been proposed to be used in primary prevention, is as part of a polypill. This is also a recent study that was conducted mostly in India. And you can see here that the TIPS study compared actually 4 regimens. So it was aspirin alone, polypill alone. The polypill included a statin and several antihypertensives, or the combination aspirin plus polypill, or the double placebo. Double placebo is shown here on the graph on the right in red, and the combination of polypill plus aspirin in green. And this was given in primary prevention, and aspirin resulted in about 30% vascular events over a period of a few years. Each of the aspirin only or the polypill only, they had about the same benefit in comparison. And of course, the winning regimen included aspirin. Now, the guidelines for aspirin and primary prevention have changed over time. I just wanted to show you here in 2016, there was colorectal cancer was also included in the USPSTF guidelines. In 2022, the USPSTF guidelines updated their aspirin recommendation for primary prevention, focused only on cardiovascular disease. Now that cancer is another completely different talk probably, but there is some suggestive data that, even from randomized trials, although it wasn't the primary endpoint necessarily, but there is randomized data that suggests that aspirin could have benefit for, in particular, colorectal cancer reduction. So in 2022, the USPSTF decided to focus on aspirin for primary prevention of cardiovascular disease. And they said to avoid it if patient is older than 60, avoid it in younger than 40. And if you're between 40 and 60, basically, if your risk for cardiovascular disease is more than 10% over 10 years, so that's more than 1% per year, then those are the people that we could consider using it for, but they have to also not be at increased risk of bleeding. So it has to be more of a personalized risk-benefit assessment and discussion with the patient, and they gave it a level C recommendation, meaning you select the patients carefully who could benefit and are harmed by it. And the 2019 American College of Cardiology, American Heart Association prevention guidelines gave it a level a level 2B, a recommendation for low-dose aspirin for primary prevention if, again, adults are not too old, so not older than 70 and not younger than 40, and if they had also a higher ASCVD risk and not at increased risk of bleeding. Now, the guidelines were careful not to mention what they really mean by higher ASCVD risk. They left it to the clinician to determine. And they did also include a level of a core 3, which is harm, that it should not be administered in anybody who's at increased risk of bleeding, or anybody should not be also given routinely for older individuals above age 70. Now, the European guidelines in general, over the past, I would say, 2 decades or so, have generally been much more conservative in terms of aspirin use for primary prevention than the American guidelines. And the European guidelines in general have said not to use aspirin. However, after the study that I just showed you, the ASCEND, I think that led to, and of course, the totality of the evidence for primary prevention, which is that there is a benefit for major vascular events. It's just not for mortality in primary prevention. And also there's a risk of bleeding, in particular GI, but also intracranial. So given those, the European guidelines in general had tended to favor, not using aspirin at all. However, in 2021, they did change a bit, and they did say that in patients who are high risk, such as those with diabetes, and specifically that was diabetes, especially if they have high or very high CVD risk, based on the data I just showed you, that low-dose aspirin may be considered for primary prevention, again, in the absence of evidence of increased risk of bleeding or other contraindications, and they gave it a level 2B recommendation. And they also said not to give it if patient is low or moderate CVD risk. They really wanted the very high primary prevention patients. The American Diabetes Association was also very similar. So they also say, don't give it if you're low risk, don't give it if you're older than 70. And of course, don't give it if the risk of aspirin exceeds that of the benefit. But in between, for the other patients, you can consider it if their risk is high enough. And if they have especially not just diabetes, but also additional risk factors for cardiovascular disease, and that it should be individualized discussion. Now that leads us to the individualized discussion is very hard. As a clinician, I'm a cardiologist, and we're all limited by our time. And I may be good at predicting somebody's cardiovascular disease risk, or at least at identifying who's high risk for cardiovascular disease. But in primary prevention, as it is in secondary prevention, it's sometimes the assessment of their bleeding risk is complex, because it's not just based on one factor. It's a multifactorial decision about their bleeding risk, as it is also for their cardiovascular risk. But since I'm a cardiologist, that's easier for me. The bleeding risk is always harder, because there are multiple factors that we have to take care of and see if they're at high risk. For example, if they've had prior GI bleeding, if they've had ulcer history, gastric ulcer, if they are they taking non-steroidal anti-inflammatory, which are over the counter, and often we don't get a good history about that. They are taking other antiplatelet or anticoagulant agents, if they have renal disease, if they have significant alcohol history or hepatic disease. Of course, older age is probably the strongest risk factor for bleeding if you're on aspirin, and also if you're not on aspirin. But older age is one of the strongest risk factors for bleeding. And what we did together with Joanne Manson and Jeffrey Ames, we actually developed this free available app. It's also on the website aspiringuide.com, and that's to help clinicians in primary prevention assess what's the risk and benefit for that patient. So we actually provide an ASCVD risk score. In this case, it's based on the Poole-Cohorst equation from the US, but basically it's a risk score assessing somebody's risk for cardiovascular disease over the next 10 years. And we also have, we ask about the questions related to bleeding, that increased risk of bleeding. And the key thing is that it's individualized, and it can actually give me an an estimated number needed to treat or number needed to harm. What's the likelihood that this patient would benefit, as opposed to just, going by general rules of thumb. So it gives you more individualized assessment. And that's all I had. And I wanted to summarize by saying that aspirin is still, a complex decision in primary prevention. But we do know now a few things, which is that it should not be used if the patient's risk of bleeding is high, in particular if they're older. There are certain cases that maybe we could get into a discussion where there are some people, for example, with a high lipoprotein little a level, LPA level, that could potentially benefit from aspirin. But in general, the decision is about assessing their cardiovascular risk and their bleeding risk and individualizing, and not to use it in low risk individuals. This really should be reserved for the high risk primary prevention population to think about. That's all I had, so thank you.
Thank you, Mora. Great introductory slides. Really well, not only introduction, really summarizing a lot of the evidence. We decided to immediately go on to Dr. Cleland.
Thank you very much. So first of all, I should say that I have recently relinquished my position as director of the Biostatistics and have now returned as Professor of Cardiology at the University of Glasgow. So I was interested to listen to Samia's talk. I hope that my talk is going to make her life a lot simpler by showing that she doesn't really need to be using aspirin at all as a cardiologist, or not very much. I don't think that the aspirin prophylaxis is rationally robust in terms of concept. I don't think that we have many results that are statistically significant. And even though we might occasionally achieve statistical significance, the results aren't clinically convincing, at least for long-term aspirin. There is, of course, a role for aspirin in the immediate aftermath of a vascular event. So why do so many doctors believe that long-term aspirin for primary or secondary prevention is effective? And it's the same for primary or secondary prevention. I don't think that we have any better evidence for secondary prevention than for primary. Well, I think sales pressures by pharmaceutical companies are important. The Aspirin Foundation was wholly funded by Bayer throughout the early years of aspirin. It was inserted within the Lancet, so you got it every week. And until I pointed out, the Lancet didn't really want to be seen to be promoting drugs, and it was only when I pointed it out to them that they then decided that they wouldn't publish it. And we should say that many companies with an interest in antiplatelet agents have persisted with this, and of course many of them are comparing themselves to aspirin or used on top of aspirin, and we really don't know where we are if they're building on a foundation of sand. There are oversimplified theories about the mechanisms of vascular occlusion. Plaque hemorrhage and rupture is probably as important or more important in stable atherosclerosis than the rupture of plaque through mechanisms other than hemorrhage. So it could be that bleeding is and actually reducing or getting rid of things that stop your platelets working might be useful. We have a problem with publication bias. I know this because if you try and publish anything untoward about aspirin, you're going to have a very steep hill to climb. The older meta-analyses were flawed. They were driven by small trials with unrealistically positive results. There was clearly publication bias, and there were exclusion of trials with inconvenient results. For instance, the PEP trial is always excluded. This had more than 13,000 patients randomized and showed a significant increase in non-fatal myocardial infarction, but it's never included in the primary prevention meta-analysis. So I don't know why. There are excuses made that your trials with aspirin never have the power to show a difference in mortality. Well, I'll show you how much power they have. They have plenty of power, and they've failed to show a difference. I think a lot of cardiologists think, well, we've got the ISIS-2 study, a study where 4 weeks of aspirin was given after myocardial infarction. If it's effective for 4 weeks, why wouldn't it be effective for longer? But you wouldn't give an antibiotic for the rest of somebody's life for a chest infection, would you? So why should we give long-term aspirin just because short-term aspirin is shown to be beneficial? And I have to say that doctors are highly intelligent people and they have fertile imaginations and they believe that data exists when it actually doesn't. Like there is a long-term trial of aspirin post-MI at a dose of less than 300 milligrams of aspirin. It doesn't exist. So what are the goals of prevention? And I would say the reduction in disability and death. You really want to prolong quality-adjusted life years or disability-adjusted life years. And some will emphasize that quality or disability is important, others that longevity are important, but ultimately both matter to all. Having 1 or 2 bad days doesn't really matter too much. For example, if you have some chest pain, and you need to see a cardiologist and your troponin happens to be up, or you have a funny turn and you see a neurologist, these might cause anxiety, but do they really matter if they don't cause any long-term disability or death? The magnitude of important benefits shouldn't be microscopic, and the benefits should far outweigh the risks, and we've been told about some of the risks. From a health services and taxpayers and clinicians' point of view, the cost per QALY or DALY disability-adjusted life years matters. And aspirin may not be so cheap. I don't know about the United States, but in the United Kingdom, most aspirin is prescribed. And when you prescribe aspirin, each prescription is going to cost you about $10 to $15 for the prescription. The cost of the aspirin is cheap, but the cost of the prescription isn't. And especially if you co-prescribe it with proton pump inhibitors, which many do to try and reduce the risk of GI bleeding, that further increase costs. And we should be concerned because I think that there are real long-term health problems with using PPIs chronically, maybe leading to an epidemic of iron deficiency anemia. Once you've got iron deficiency anemia, you're going to double or triple your risk of dying. How do cardiovascular events prevent? Well, for myocardial infarction, hospital admission, so perhaps 600,000 patients per year in the USA. But there's also sudden death out of hospital, maybe another 300,000 patients per year. And then if you look at the number of silent myocardial infarctions, it's at least as great as the number of people coming to hospital with a myocardial infarction. So we have another 600,000. So it's a lot of myocardial infarctions are happening, but perhaps only 600,000 of these might end up appearing in the aspirin trials statistics or those sorts of patients. For cerebral infarction, it's pretty similar number of stroke admissions, similar about half the number presenting with TIA, not necessarily to be admitted to hospital. It's uncertain how many out-of-hospital sudden deaths are due to cerebral infarction or bleeding. But silent myocardial infarction has been estimated to be about 10 million people per year in the USA alone. So big problem. Problem is that sudden death is increased in many aspirin trials. So, but they don't count for your myocardial infarctions. This was true in the AMOS trial, the Paris 1 and 2 trials, and the US Physicians trial. And what about silent myocardial infarctions? Well, there was a primary prevention trial called HOT, which looked at both noisy and silent myocardial infarctions. They like to emphasize the noisy infarcts because they saw a reduction. They don't like to mention the fact that they saw a trend to increase silent myocardial infarction. And sorry, that should read all myocardial infarction in the third row. That didn't change at all. And of course, cardiovascular death didn't change either. So maybe the problem is just that we're missing most of the myocardial infarctions, and that might account, changes in the presentation of disease might account for what we see in the Aspirin meta-analysis. This is a nice paper from JAMA, meta-analysis, showing that non-fatal MI is not a useful surrogate for cardiovascular or all-cause mortality in primary prevention randomized trials. So we have to look at something else. The only primary prevention trial of aspirin that measured both disability and death was Aspirin, had 19,000 patients enrolled, median follow-up 4.7 years. The trial was stopped for futility with a significant increase in all-cause mortality, a significant increase in cancer mortality, and only a very modest and non-significant reduction in cardiovascular mortality. And this is the largest well, it isn't the largest primary prevention trial, but it is one of the largest. The largest trial, of course, is the Women's Health Initiative trial. That has more patient years of follow-up than all the rest. What we've got here is some of the largest, not all, but there are 21,000 randomized trials with 173,000 participants and more than 1 million patient years of follow-up, and 8,466 deaths. If you can't show an effect with that number of deaths, then you've really got an issue. And you can see in all of these trials, if you look at the number of deaths or cardiovascular deaths prevented per 1,000 patient years, it's generally less than 1. There was actually an increase, of course, in the Aspirin trial. In terms of stroke, really not much happening. And in fact, in the British Doctors study, one of the first studies, there was a significant increase in disabling stroke. So if you actually look at the number of people benefiting in these trials per decade of therapy, it is vanishingly small. And, you know, if there was a significant reduction in death, even if it was true, this would be about 2 deaths per 1,000-person decades of treatment. So no benefit for the other 998 over these decades. So extremely low evidence of benefit in terms of mortality. What about cancer? It's mentioned. Here are 4 of the largest trials and also the Women's Health Initiative. You can see in terms of any cancer, there really is no reduction in cancers. There was actually a significant increase in cancer incidence in the Japanese primary prevention study. In terms of cancer deaths, as I've already mentioned, an increase in the Aspirin trial. And that seemed to be because of an increase in presentation with stage 4 metastatic cancer in the Aspirin trial. And of course, a recent trial on breast cancer was stopped early because of suggestion of harm from the introduction of aspirin in these ladies with breast cancer. So a real concern here from 2 trials, perhaps 3 trials, that we may be making cancer worse with aspirin rather than better. So that's the primary prevention. What about secondary prevention? This is the study that many cardiologists will think of, the ISIS-2 trial, comparing aspirin with placebo for acute myocardial infarction. The dose of aspirin was 160 milligrams per day, and it was given for 28 days only, and then it was stopped. And there's no record of subsequent treatment. There was no convincing evidence from prior meta-analysis of a benefit from aspirin. And you can see in the ISIS-1 study, which was conducted by the same investigators, only 5% of patients were discharged on any antiplatelet agent. So people were not using antiplatelet agents in the mid-1980s. You can see after 28 days that aspirin reduced vascular deaths and indeed all-cause mortality. You can see that after 2 years, having received 28 days of aspirin, there was still a benefit And in fact, if you go out to 10 years since randomization in that blue square down at the right-hand, bottom right-hand of your screen, still a benefit apparent after 10 years. So you don't need to give aspirin for more than 28 days after myocardial infarction to achieve these sorts of results. I think a 4 to 12 week course of aspirin after an acute vascular event probably suffices. You might say, what about stroke? Well, this is a nice analysis from Peter Rothwell, who's another expert on aspirin. You can see that in the first 6 weeks, there is a large benefit from giving aspirin. Notice that the biggest effect is on non-disabling strokes. It's the pink ones that we're really concerned about, the disabling or fatal strokes. You can see beyond 12 weeks, there really is no benefit from aspirin after a stroke event. Now, you might be interested in a meta-analysis of long-term trials of aspirin less than 300 milligrams per day after myocardial infarction. The meta-analysis is very easy to do because it's there on your screen. It's a blank. There isn't anything to show you. Now, there are a little bit of data I'll show you in a moment on very high doses of aspirin and showing whether there's some benefit. Could the lower doses of aspirin that we're used to using today be any as good as or better than higher doses, the 300 milligrams? This is the adaptable study comparing 81 milligrams with 325 milligrams of aspirin for patients with an indication, a secondary indication for aspirin, showing no difference in these doses, but that may indicate that neither dose was effective. We don't have, unfortunately, a placebo group or a no aspirin group, but we do have some idea about the major bleeding risk and other events, no difference. But perhaps 10 milligrams of aspirin twice a week would be no less effective, or maybe just giving no aspirin at all. Here's a meta-analysis of all the long-term post-MI trials of aspirin, regardless of dose, and you can see something very curious. This is a funnel plot. It should be symmetrical, so there should be small trials that were negative, but of course, publication bias stops those appearing in the literature. You'll only get your small trial published if it's outrageously positive, and that's what drives the secondary prevention meta-analysis. Down at the bottom, you can see the AMOS trial, the largest post-infarction trial ever done. 4,500 patients with greater than 3 years of follow-up, and you can see there is a trend to harm rather than to benefit when it comes to mortality. These are the two largest randomized trials of aspirin for chronic atherosclerotic vascular disease, the AMOS trial and the Swedish aspirin prevention trial, the SAPAT. These trials showed a very small benefit, by and large a non-significant benefit. There's no benefit in stroke, very small differences. In terms of myocardial infarction, there were some trends which did achieve statistical significance in the Swedish trial, but remember they didn't collect the silent infarcts and they didn't include the sudden deaths in the myocardial infarction group. And when it comes down to deaths, non-significant impact on mortality. You're talking about 3 more deaths per 1,000 patient years in the AMOS study and perhaps 6 fewer per 1,000 patient years in SAPAT. So very small differences. These were all in the pre-statin era, and it may be that statins have rendered aspirin even more redundant than it was before. Maybe not, but how do we know? Just putting these on a graph, This shows you the AMOS and the Paris-2 trials, the two largest trials with a placebo control. Perhaps there's a little bit of a trend to benefit if you combine aspirin with dipyridamole, but how many people do that these days? Very large doses of aspirin, I admit that. But on the other hand, you don't have any long-term trials post-infarction of 75, 80 milligrams of aspirin. And aspirin might take away the benefits of other treatments that we know do work. So here's the impact of ACE inhibitors in the presence and absence of aspirin. In the absence of aspirin, in both the SOLVE treatment, SOLVE prevention, and the HOPE trials, there is a substantial benefit from the ACE inhibitor. You can see that that isn't needed or lost in the presence of aspirin. So in conclusion, I think the whole antiplatelet and indeed dual antiplatelet therapy hypothesis is a house of cards. I think we're being sold a lot of spin. I would suggest that people go back and look at the evidence, and that with the exception of the 4 to 12 weeks after an acute vascular event, I don't really think there's any evidence that aspirin reduces chronic disability or death. I think there are serious potential risks of aspirin, including the bleeding risk, iron deficiency anemia, and accelerated cancer progression. So if you can find a trial with convincing evidence, please let me know. And please let me know what dose of aspirin, if any, is effective and safe. And just remember, an absence of evidence of harm cannot be interpreted as evidence of benefit. So thank you.
Thank you so much. So this sounds very provocative, surely, to many clinicians. And I would suggest to give the word back now to Samia and to hear from her about her ideas.
Yeah, thank you, John. And I think, I don't disagree with you on many of the points that you brought up. I do think that a lot of the data for aspirin in secondary prevention, especially when you're comparing, aspirin versus placebo, as opposed to, say, in a combination with other antiplatelets, I think a lot of that data is really old. And I do also agree with you about the point that, the patients that we're seeing today are treated very differently from they were, say, 20 years ago when these trials were conducted. The patients we're seeing now are pretty much, at least in cardiovascular and secondary prevention, a lot of them, if not most or all of them, are on, statins, often high-intensity statins, often, ACE inhibitors, as you mentioned, multiple other guideline-directed medical therapy regimens, and they're very different patient population, even as you suggested that the myocardial infarctions are, even the biology of it may have changed over time, and maybe that's due to statins or other reasons, but even the biology, as you said, like we're now seeing for myocardial infarction, it's more, say, the type 2 as opposed to the type 1s that we used to see where more, have gone down over time epidemiologically across the board, at least in North America and in Europe. So I do think the patient population has changed a lot compared to when a lot of these trials were conducted. I do agree with you that the long-term data that we would like is especially in secondary prevention. Now, in primary prevention, on average, the studies have been about 5 years. There are, as I showed you, Ascend 7 years, and the women's health study that you mentioned is 10 years for the intervention period, and we have longer term follow-up. So those points I definitely agree on. I do think also aspirin has harm, as was pointed out, and I do also think that bleeding is the way aspirin works, as you mentioned. So some of the benefit. So that you were getting the benefit and harm because of the mechanism of action of aspirin through cyclooxygenase inhibition and effects on thromboxane E2 and other prostacyclins. So that's how it gets complicated. I do think also we need trials for when do we stop aspirin. As you said, and clinicians and in clinical care, often when somebody gets started on something, it never gets stopped. So often we get patients who are now 90 and, or just as an example, but often, people don't reconsider, for example, the medications that somebody is on, and they don't take that into account. We're not very good at taking that into account. It's when do you stop something? maybe that is the risk aversion of like trying to stop something that somebody else started. Often it's started by somebody else, maybe primary care or somebody else. And so in clinical care, it gets complex. I do think I want to point out a few points, though, about aspirin and prime prevention. One is that the majority of the trials I showed that have been included in the meta-analyses, for example, a lot of these, the patient's absolute risk for cardiovascular disease is quite low. So we're dealing with, even the women's health study. If you look at the women's health study, the baseline risk in the women's health study overall for cardiovascular disease is like a few percent. So we take somebody who's, say, low risk in the near term, and we do a trial that's, say, 5 years or at most 10 years. It's hard to see potentially a benefit when the absolute risk of the patient is low. And I think I completely agree with the guidelines that have said if you're low or moderate risk even in prime prevention, do not use aspirin. I think that the challenging part is when you see somebody who's high risk, such as diabetes, and often they have other cardiovascular risk factors, and we know even their short-term risk may be high. So those are the patients where I do think individualizing the risk benefit. Based on the totality of the data, there is benefit for myocardial infarction and for ischemic stroke. There is increased risk for hemorrhagic stroke, and there's no evidence for reduction in all-cause mortality and no reduction in disability, but you wouldn't expect aspirin to necessarily reduce disability.
Then why do we give it?
Yeah. Right. So it would be in primary prevention, it would be for reducing myocardial infarction and ischemic stroke.
But if the myocardial infarction doesn't reduce your risk of heart failure, and it doesn't reduce your risk of sudden death, and it doesn't reduce your risk of arrhythmia, and it doesn't reduce your risk of death, what's the point of taking an aspirin to have, in 1 in 1,000 patients not having a hospitalization and shaking hands with a cardiologist? Do you really want to take aspirin and all the risk that it entails just to avoid shaking hands with a cardiologist once?
Right. I mean, that's a good question. I guess the question could be, why do we take statins? Also statins reduce myocardial infarction, reduce ischemic stroke.
Reduce death for secondary prevention. And indeed, WASCOPs would suggest for primary prevention. So we do have trials of statins, of which I'm a great believer in statins. I think, I've been taking one for nigh on 30 years, so I have a very bad family history, but I'm not taking aspirin.
I'm a believer in statins too, because they have benefit. I'm just trying to show the parallels for if one is trying to reduce.
But I don't think there's no parallel between aspirin and statins. I mean, statins have been highly effective and reduce lots of bad things happening to you and save lives, which aspirin does if you give it for 4 weeks after a heart attack. But then just like an antibiotic, you should stop.
I do agree with you that we do need more data as to when do we stop. I completely agree on that point. I think there is some registry data, though, from, like, say, the Swede Heart Registry, and there's some other studies suggesting. Now, again, these are registry data with all the confound. It's not a trial. That's why I think I agree with you. We do need trials that suggested that among people who had their aspirin stopped, there was increased risk of events in the 1 month after stopping. Again, that's observational data. And could be confounded by many factors. And I do think we do need trials as to when do we stop. I do agree with you. For example, beta blockers, we used to take them for granted that you just keep them going. And then, based on the newer evidence, so I do agree these are important questions to answer because we don't have data for some of the questions that you brought up.
Yeah, so I think it is important. And it's also, we need to be careful with revolutions like stopping aspirin 4 weeks after a myocardial infarction. We do live in a new era with modern stents, maybe again after 4 to 12 weeks. You don't need your antiplatelets anymore. So I think that, the cautious way out of this would be to start using much lower doses of antiplatelet agents. I think we've got pretty good evidence that by 3 months you can get rid of your DAPT. There really isn't much advantage beyond 3 months, is there? And I would argue that the least effective antiplatelet agent is the most effective clinically long term. So going on to clopidogrel monotherapy is probably a better outcome than anything else, isn't there? I mean, it's not something I've looked at with a great deal of care, so I'm happy to be corrected. But I think the host exam, didn't it compare aspirin and clopidogrel long term, and didn't clopidogrel do pretty good? The less effective the antiplatelet agent, the better it does.
We would have loved to ask you about CKD patients, particularly me as a nephrologist, but I'm aware that you will say, well, show me the data. We have some subgroup analysis. There is one study going on, I think even in the UK, the ATTACK study. But what about low-dose DOACs, like loader of rivaroxaban, as done in the COMPASS study? Do you still see some place for that intervention?
Yeah, I mean, I think the COMPASS trial is very interesting. It would have been far more interesting had they compared the same dose of rivaroxaban without aspirin as opposed to monkeying around with the rivaroxaban dose. It's rivaroxaban all by itself didn't seem to be too bad at a low dose, but as I say, very confounded because we don't have a placebo group. We don't know how much benefit anybody got. Maybe they would have been best just focusing on making sure they were on the right dose of statin.
Yeah, I mean, the rivaroxaban was the winning regimen in COMPASS was rivaroxaban plus aspirin. I agree with John that it was a very low dose, to 2.5 twice a day of rivaroxaban. There was the there's the polypill equivalent in secondary prevention of the study I mentioned, which I didn't show a slide of because I didn't focus on secondary prevention. But there was a recent trial, the SELECT trial, that was conducted mostly in Europe. And that one was secondary prevention, and they did include in it aspirin. I think it was 100 milligrams as part of the polypill regimen, which also included statin and ACE inhibitors. And that one did show benefit. And it was a few years of follow-up. That's more of a modern population, contemporary, if you will. But again, it was a combination pill.
We're running a little out of time, but if I may ask you that last question, but it'll probably remain speculation. Could you speculate on other P2Y12 inhibitors such as ticagrelor? You alluded to the 3 months or 1 month DAPT, and the data. A lot of the data we have is on ticagrelor monotherapy after that. Would you agree, both of you? And is that the better regimen really for long term, maybe?
Well, they haven't compared themselves to placebo, so we don't know.
We don't have comparison of ticagrelor with the other P2Y inhibitors in terms of long term. So, but I do agree with John that there's always a risk and a benefit. And what we do know now also more and more of is that the increased risk of bleeding also matters for mortality. So, so that question, I think, comes back again. Your question comes back to, well, what's the patient's risk for atherosclerotic events versus their risk of bleeding? And if their risk for atherosclerotic events or atherothrombotic events really is greater, then you want to use a more potent antiplatelet agent. But again, you have more risk of bleeding, and that's what COMPASS found that too with the DOAC, that there was increased risk of bleeding when aspirin was added on top of the rivaroxaban.
Yeah. So I'm very concerned, not just about the bleeding, but about the actions that we take to try and reduce the bleeding. And it's this chronic use of proton pump inhibitors. And there's an epidemic of iron deficiency developing in the atherosclerotic cardiovascular disease population. It's associated with a substantial increase in mortality and anemia, disability, etc.
And actually, I want to mention there also that many people aren't aware of it, but Compass actually did have another arm. It was a 2x2 factorial, and the other arm was actually testing PPI and also testing to see if, among the people who were randomized, was there benefit also to the PPI on top of, and that study is not well known because it was published, I think, in a relatively minor GI journal. But anyway, it's not New England Journal or Lancet, so we didn't, but there was no benefit for PPI in terms of, compared to placebo, in terms of even.
So I thought, I may have got it wrong, but I thought there was a reduction in short-term risk of bleeding. But of course, the risk of the PPIs is being on them for years and years and years, because if you cut your gastric acidity enough, you just won't absorb iron. I don't think it's so much. I'd love to blame aspirin, everything on aspirin, but I suspect it's not the aspirin that increases your GI blood loss. I think it's the proton pump inhibitor that cuts your gastric acidity and then you don't absorb iron. So I think it's the PPI is the criminal here, but it's given because of the aspirin. So it's a mess, and we need proper placebo-controlled randomized trials. If we can't have those, then we need a proper dose ranging trial that really takes us down to the doses of aspirin that we're told are all that you require, which I can't remember. I think it's something like 25 milligrams of aspirin 3 times a week or something like that is supposed to give you all the platelet inhibition you need. And, let's do that. And then we can gradually get down to 1 milligram and then 0.
This might be sort of a good final word. We're seeing some agreement in your discussion there. Gunnar and I were really watching and enjoying your I think very fruitful discussion, which perfectly shows the lack of data there is, and we're very happy and very grateful that you two contributed a lot to the data that there is, and hope to see some more of that. And I think also for the sake of time, we'd like to thank you today for this interview and presentation and great discussion. And I think you offered a lot to our listeners and watchers and viewers. So thank you very much, both of you. And
sorry. Yeah, thank you very much indeed.
Having me.